of erythrocyte, which is also involved in transporting of CO2. Then it also contains hemoglobin, which facilitates this transportation. And platelets, which occupy around 1%. We all know the role of leukocytes in defense mechanism and the role of platelet in primary hemostasis. So we have this is the blood components. When you get the blood sample from the peripheral vessels, you get the blood. You put it in the tube, which contain ADTA anticoagulant, and you do centrifugation. The red cell will go down, you see there on the slide. Then in the and the leukocytes, then up there in 55%. So the total amount of blood cell is like 7.6 of the total body weight. We have what we call hematocrits, which is the volume occupied by the red cells. In male, it's somehow higher compared to the female. Then you have the composition of the plasma, which contain mostly water, but also we have some three important proteins, which are mostly albumin, globulin, and fibrinogen, which is the number one coagulation factor. Those are the composition of the plasma. Again, this one we have said. Then among the white cells, we have the lymphocytes, granulocyte, as it has granules in the cytoplasm. We call them granulocyte. Then in the granulocyte, we have three types: basophil, neutrophil, and eosinophil. This is the image of the tube when you get centrifugation by separating the blood components. When you make the peripheral blood film, meaning that you get the sample, you get the blood sample, you take a slide where you make the smear. That is how you look on the microscope, the cell will look like. So here we have the red cells, which are nucleated. On the center, you have a centropala. That's where the nucleus was. Then these are different type of white cells. For example, this one is neutrophil. This one having a like orange granules here is eosinophil. This is the biggest one, which has like a nucleus having a bean shape, which is a largest cell. It's a monocyte. Then here down, we see huge granules. These are basophil. This is a small lymphocyte. This is a reactive lymphocyte with somehow atypical cytoplasm. So in the middle, we can see some granules in between the red cells. Those are platelets. So by hematology, what are we going to know? So we are going to study the primary elements of blood cells. And we should also understand that the alteration in the blood usually result from the disease, then being the primary cause of the disease, meaning that, for example, the patient may have infection like TB, then he come to you with anemia or raised red white cells or decrease of platelets, not because of the diseases from the hematological component, but just it's something secondary to systemic diseases. So that is mostly the manifestation of alteration of hematological parameter. So what are the parameters which are measures in hematology? We have the full blood count. The machine now we are using, in the past they used to use a manual count, but now it's an automated machine which gives you all the hematological components. So it gives you full blood counts, which contain red blood cell counts, contain white blood count and platelet count. hematocrit, but also it gives you red cell indices, which are mean corpuscular volume, which is MCV or MCHC. So we come in details on those details. So to make a balance between cell production, release, and survival, we should be having control on the production of the cells, survival of the cell, so that this process should be regulated to make the organism to have stable hematological parameters. So when there is increased destruction, the patient may have a cytopenia, which means decrease in cell count, or if there is the decreased production, so the patient may also have cytopenia, meaning that we need to have a balance between cell production and cell destruction. So before interpreting hematological parameters, there are some criteria to consider. We have physiological changes, which may depend on the age of the patient. We have gender, we have location of the patient. Then pathological changes may occur when there is a diseases or injury. Then we have to know how to calculate the normal range on healthy individuals. So it's advised that each population should calculate the local blood cell values so that you have your local values. So by starting hematology, we should also understand how those blood cells are formed. So which is the process of hematopoiesis, which is the term describing how the formation and development of the blood cells. So the cells of the blood cell are being lost or destroyed after spending their normal lifespan. So to maintain this, the cells have the capacity of self-renewal. So that means in case of need, there will be signal stimulating the production of the cells. So the system involved, there is a proliferation of progenitor cells, which are the stem cells. The stem cell will make proliferation, then differentiation and maturation. Then when they're mature cell, that's when the bone marrow will release those cells in the peripheral blood. So all the process of formation is done in the bone marrow. It's only when the cells are mature, that's when there will be release of the cells in the bloodstream. So we should also understand what is the normal lifespan for each blood component, granulocyte, erythrocyte, and lymphocyte. So we'll go through each of them. But the originary, it's starting from the stem cells, which occupy 0.01% to 0.05% of the marrow cells. So that's the quantity. They have the capacity of self-renewal and plasticity. Stem cell will develop to progenitor cells, which are the cells which are developing, but they are restricted to restriction to one type of the cell. Let's say we have lymphocyte progenitors. So those are the cells which are already committed to develop lymphocytes. Then we have myeloid cell progenitors, which are committed to produce myeloid cells. Then you have mature cells, which take from the more developed and restricted progenitors. So this image show from the beginning how things are happening. We have here on the beginning we have pluripotent stem cells, which has pluripotent capacity, meaning it's able to produce all hematopoietic cells, including myeloid cells and lymphoid cells. When I say Myeloid cells, it means all the blood cells except the lymphocyte. So on the site of the myeloid cells, we have colony-forming unity of erythrocyte, colony-forming unit of erythrocyte, which will produce mature red cells. We have from megakaryocytes, which will produce platelets. We have granulocytes and monocytes, which will produce myeloblasts, also monocytes, you can see in the image. Then we have eosinophil, basophil, and so on. So those are from here, these are progenitor cells. Then we have a lymphoid stem cell, which will either produce pre-B cells or thymocytes, which give T lymphocyte and B lymphocyte. Then we have also natural killer cells, which are coming from them. Then from the B lymphocyte, we have production of immunoglobulin. We will see more details in immunology, where those B cells produce immunoglobulin, five types of immunoglobulin, and become plasma cells. So this plasma cell, you have to understand it because there is also a pathology in hematology, cancers, which we call multiple myeloma. In that one, there will be excess production of plasma cell. So this is how it is. The second one, it's also the same picture showing how the progenitor cell are differentiating, maturating to the blood cells, and from the blood mature cells are the one to be found in the peripheral blood. Is it clear for everyone? Hello?
Hello.
Are you following?
Yes.
Yes, we are following.
Okay. So let's go now on the stem cells. We have this, you have seen for the pluripotent stem cell, which has the capacity of producing all hematopoietic stem cell. It has self-renewal capacity, and it has the capacity to self-reproduction, and as cell increase in number, they differentiate as well. So this is really a mechanism which is continuous. In the case of need, it's again producing, that make the patient to be somehow in balance. So it have multipotentiality, meaning that you have the all level 4 hematopoietic lineage. So again, that is the property. After there's stem cells, you have said about the progenitor cells, which has they are committed to produce one differentiated lineage. For like you can say, red cell progenitors, neutrophil progenitors. So these are somehow restricted to produce one type of the cells. So they become progressively more restrictive in their differentiation and their capacities. Yeah, the late one may have one lineage of cell production. So we have, as we say, we have to have balance between cell production and cell death. That's make the individual to be somehow stabilized when if the two mechanisms are well controlled and regulated. So what we need to have so that the hematopoiesis keep producing cell, we have local and immoral regulation, meaning local mean the environment on the bone marrow, which is the big main site of cell production. So local environment should be well, meaning that any toxicity, uh, any bone marrow infiltration by any cancer or any infection, any toxicity may affect the cell production. Apart that, we have the immoral regulation. So those are the two which should be there to support that. So for that we need the hematopoietic growth factors. So each colony has its specific growth factors. We have granulocyte macrophage colony stimulating factor, we have macrophage colony stimulating factor, and so on. For the red cell, where we are going to insist in case of anemia, we have erythropoietin, which is mostly produced in 90% on the kidney, then 10% on the liver. Then we have thrombopoietin, which will be stimulating the production of megakaryopoiesis, which is production of platelet. So we have also cytokine, which may also interfere with cell production. This is the list of uh, cytokines, but also we have growth factors. We have said about it, stimulating each one. So we have this image here showing how local environment, cell control, hematopoietic growth factors, and apoptosis are the three factors which has to be stabilized and work together to maintain a good hematopoiesis. Anything coming on this one of these in excess may cause disruption of the blood production. If there is an excess of apoptosis, that may cause a decreased number of the cells. Any issue with the growth factor may make the decreased production. Then also local environment may also disrupt the cell production. So where does the hematopoiesis take place? We usually take starting from the second week of intrauterine, where it's done on the embryo in yolk sac. Then from second, after some weeks from the first month, that's when the liver, the spleen will take place. Then from the fourth month, that's when the bone marrow took place. So normally the site of apart the intrauterus life, the site of hematopoiesis is located in the bone marrow in normal condition, of course. So sometimes if there's diseases, the hematopoiesis may take place in the spleen or in the liver, even lymph nodes when there is a disease ongoing. So we have talked about from the 19th day, that's how it starts on the yolk sac. Then it's mostly the erythrocytes which are produced, and the rest will come up later. Then the fetal liver, after that period, will be the site of production. Then the liver, the thymus, the lymph node will serve as monocytes. So as we said, after around 4 months to 6 months, that's when the bone marrow take over until the adult age. So this again, the same imaging showing now in red which area of the bones are rich in hematopoiesis. So you can see that the pelvis is really rich in cell production. You can see the sternum, the long bones mostly on the head of the humerus and the femur, but also up there on the skull. So when you want to do bone marrow aspiration biopsy, we mostly go to the pelvis or the sternum. That's when you get enough bone marrow element. So hematopoiesis, as I said, from the 4th month of intrauterus life, it is only done in the bone marrow in normal condition. We call it medullary hematopoiesis. When it is outside of the bone marrow, it's called extramedullary hematopoiesis. Then in fetal life, it is only mostly in the liver and the spleen. Then when the bone marrow, when in the adult age, when the spleen and the liver are the site of hematopoiesis, that make them to be enlarged. So you may find some people with splenomegaly or hepatomegaly as the hematopoiesis is taking place in that area. We have tissues which are involved either in proliferation or maturation or destruction of the cells. Those are called hematopoietic tissues. So who can guess what are the hematopoietic tissues, you know? What are the hematopoietic tissues, you know? Any tissue involved either in proliferation, maturation, or destruction. Anyone knows? Hello? Who can tell us what are those hematopoietic tissues? Just cite them, mention them. Any idea?
Bone marrow.
So bone marrow, what else?
The liver.
The liver, next.
Spleen.
Spleen, what else?
Peripheral blood.
No, I'm saying the blood production, proliferation, or destruction. So the hematopoietic tissues.
Thymus gland.
Thymus, what else again? So we have said bone marrow, which are the main organ, liver, spleen,
and lymph nodes.
lymph node, and thymus. So those are the most good number of the tissue. So we have we have reticuloendothelial system, which more mononuclear and phagocyte system. We have the spleen, which usually collects the old cells by what we call cooling. So it filter the old cell, damaged cell to be removed, but also it also remove of the particles which are abnormal red cell membrane, which we call pitting. Then we have also mechanism playing role in the defense mechanism by putting together antigen and antibody, so making that role. So we have in case of splenomegaly, we have excess of cell destruction because there will be hypersplenism, but also after removing the spleen, you may see that the role which was done by the spleen is decreased. So you may be seeing most of the age damaged cells still circulating in the bloodstream, or even increased number of the cells. So if you find someone with increase of platelets after splenectomy, so don't find it strange. It's just because the spleen is no longer there. Mostly the role will be played by the liver, but not the same as the spleen. So the liver complaining to the spleen, the spleen was the most one involved in the cell destruction. So we have talked about hypersplenism, meaning that there is hyperactivity of the spleen in case of spleen enlargement, which is splenomegaly. that will be causing pancytopenia, meaning the decrease in red cell, white cell, and platelet. That we are discussing about the cause of splenomegaly. Sometimes it may be just primary, where you cannot find any underlying condition, but we have also what we have a secondary one, which may be due to inflammatory diseases, infectious diseases, and so on. The second organ is the lymph nodes, which is composed by the lymph node and lymphatic vessels that drain into the left and right lymphatic ducts. It's composed by the lymphocyte, macrophage, and reticular network. The thymus, we have seen that it really serves in the maturation of T lymphocyte into immunocompetent T cells. Then thymosin plays a role in this process. Now let's come back to the bone marrow, which is the primary main organ involved in this hematopoiesis. Bone marrow is a sponge bone, which is in adult age divided by two, meaning that we have half producing and half non-producing. So the one producing, which is active, it's called red marrow. Then the other one, which is on rest, not producing, is called yellow marrow. Then it contains all of the erythroid precursors, leukocyte precursors, and platelet precursors. As I said, the rate between production and non-production in 50-50 in adult age, but that means also in case of need, even the yellow one, which is not producing, may be active and produce most of cells. So we call it hyperplastic bone marrow when there is a condition causing the bone marrow, the yellow bone marrow, to be active and also to produce blood cells. So that will make an excess of number of the cell in the bone marrow as the inactive one is producing. So what are the conditions which may cause the bone marrow to increase the production? It's usually when there is ineffective hematopoiesis, but also the degree of hyperplastic will depend on the severity and the duration of the underlying condition. So we have mostly after acute blood loss, where there is a temporary replacement of the yellow marrow. We have severe chronic anemia, which may also increase the bone marrow to signal to increase the cell production, but also in case of malignancy, where, let's say, in case of leukemias, where there will be overproduction of the cells. So all the bone marrow, including the yellow one, the red one, will be in hyperproduction. So those are the hyperplastic condition that make the bone marrow to have overproduction of the cells. The opposite is hypoplastic marrow, meaning any condition, especially when we said environment condition also play a role on that. If there is any chemical exposure to the bone marrow, any genetic issues like mutation and so on. We have also myeloproliferative diseases when the bone marrow is in overproduction for several times. That may make the bone marrow to be becoming fibrotic. So when the bone marrow is fibrotic, it will no longer play the same role. So that's also making, so in that condition, you have the active marrow, which is the red marrow, is no longer producing normally. So the bone marrow will be hypoplastic, will decrease cell production. So this is the structure of the bone marrow. You can see it on this image. We have the progenitor cells. We have the megakaryocyte here in blue. It is the histiocyte, we fit the platelets and so on. So different type. Here it's not very clear. So the three images, as you see here, it's just summarizing what we have said. On the first images, you see it's a normal bone marrow. The whitish one is the fatty one, occupying by the yellow marrow, not producing. When you see the image, it's like 50-50, 50 red and 50 fat or yellow. Then the middle one, it is hypoplastic marrow, meaning that even the red marrow is replaced by fat one, not producing inactive marrow. So here, some patient having this will have decreased cell production, even having cytopenia or pancytopenia, all cell decrease. The other image here is hyperplastic, meaning that even the yellow or fat is now replaced by the active one, which is red. So this is hyperplastic marrow. Someone with severe hemolysis will have hyperplastic marrow. Acute blood loss will present like hyperplastic, and so on. So remember that images hyperplastic, hypoplastic, and which condition may cause each of them. So it's the same image. Lastly, we have also the liver playing the role in cell production, mostly in intrauterus life, but also it played the same role as the spleen, but less than the spleen. This is played by the Kupffer cells, which also act as a filter of damaged or aid cell as the spleen. So if there is a excess of bone marrow production, especially in case of hyperplastic bone marrow, the bone marrow can be supported by the spleen or the liver, taking over the cell production. So in summary, those are the blood cell forming cell. We have the thymus, we have the bone marrow, lymph node, and spleen and cell. So the mature blood cell has the limited lifespan, and they have we have seen the mechanism of renewal from the stem cells. In case of need, they just a signal coming to the bone marrow to initiate the cell production, as it's a self-renewal process. So this one are just repetition. Pluripotent cell, we have this is from the stem cell. We have committed progenitor cell, and we have mature cells. So this is again a repetition of the first one. We don't need to repeat it again. Let's go to the erythropoiesis, which is the production of the red cells. We come back to that because most of the hematological diseases are on anemia, which occupy most of the patient conditions. So we'll insist more on red cell production. So lifespan of the red cell is around 120 days. They are anucleated. They lose their nucleus during the process of differentiation. They have a biconcave disc, which help them to move smoothly to the blood vessels, and it has elasticity, which make them also to move through the blood component. It's usually regulated by the production of erythropoietin, but also apart the erythropoietin, we need also some micronutrient like iron, we have folic acid, vitamin B12, and other elements like thyroid hormone to facilitate the erythropoiesis. So on this picture, you may see how from the precursors we have a proerythroblast, which is the earlier red cell. It gets mutation, division to basophilic erythroblast. The large, when the cell is still immature at the last level, it's huge, and plus it is maturating, it becomes smaller in size. So you can see the images. From this, we have basophilic erythroblasts, and from basophilic, we have a polychromatophilic erythroblasts. That's when you see even the cytoplasm is now becoming in pink. So here it's again starting production of hemoglobin. Then from this, we have orthochromatic erythroblast. From orthochromatic one, we have uh, when the cell release the nucleus and become reticulocyte. So reticulocyte, it's from the orthochromatic when it release the nucleus. Then at the stage of reticulocyte, that's when the bone marrow will release the reticulocyte in the bloodstream. So all the maturation processes are done in the bone marrow. It's the level of the reticulocyte. That's when the cell will be released in the bloodstream. The reticulocyte will spend 1 to 2 days in the bloodstream and become mature erythrocyte. Here you can see erythrocytes there. This is the image of erythroblasts, and this declated cell you can see there. But this mostly you don't see it in the peripheral blood film. We should be seeing it in the bone marrow. But when there is a pathological condition, you can also see them in the peripheral blood film. We have for the granulocytes, we have granulocytes because they have granules in the cytoplasm. We have neutrophil, eosinophil, and basophil. Again, only mature cells are present in the peripheral blood film. For each cell, you have its description. You have a neutrophil which has 2 to 5 lobes. They have granules. They spend around 10 hours in the peripheral blood and they are destroyed. We have the precursors, which are from the myeloblasts. We have promyelocytes, myelocytes, metamyelocytes, and bands. So those are here. You can see from the image here. This is the myeloblasts. We have metamyelocytes, meaning that the nucleus is now starting to be endartered, so meaning to start segmentation, but still on the beginning. After the metamyelocyte, we have the bands. Still, the nucleus is becoming smaller, now starting to get like a segmented. Then in the neutrophil, you have clear nuclear segmentation. So this is neutrophil kinetics from the stage of reported stem cell to the metamyelocytes to the band neutrophil. It spent like 6 to 10 days. So it takes 6 to 10 days. Then from the bloodstream, it spent 6 to 10 hours. That is for neutrophils. Next, we have a monocyte, which is the largest cell, which has an oval or indented nucleus. So the nucleus is like a bean-shaped nucleus. Then monocytes may go to the tissue and become macrophages, and it has specific function depending on the site of the site. Lymphocytes will be mostly a study in course of immunology. So we have immunological component cells, we have primary lymphoid organs and secondary one. Then they have B and T lymphocyte and NK lymphocyte. So these details will be mostly studies in the immunology course. You will see what are the type of immunoglobulin produced by the B cells, and we see how is the normal lymphopoiesis. So lastly, we have thrombocytes, which play a big role in the primary hemostasis. We have the lifespan is 7 to 10 days. So knowing the lifespan of a cell, it helps you to know if I transfuse my patient today, I'm giving her or him platelet transfusion. When do I expect to check the control or to transfuse again if the patient is not able to produce his own platelets. So it's better to know the lifespan. So the lifespan of the platelet is around 7 to 10 days. It becomes from the fragmentation of the cytoplasm of the megakaryocyte, which undermaking endomitotic division, then mostly are destroyed in the spleen. So here you see the images from the megakaryocytes. They have cytoplasmic granules and they release the granule outside. Then those are the platelets there you can see. So in summary, what is hematopoiesis? We should understand that. So what do we need for hematopoiesis? It's necessary for the survival. To make it well produced and well normal, we need to have control of multiple factors. We have said about the local environment, immunoregulation, and apoptosis. We have also insist on the bone marrow local environment. It is necessary for normal hematopoiesis, but also remember any decreased production may also cause cytopenia or decrease in cell number. So this is all for hematopoiesis. Now we are going to focus on each condition, which are pathology of the red cell, then we'll go to pathology of the white cell, then we'll go to coagulation, which will involve also hemostasis, primary hemostasis, where we talk about abnormality of the platelets. That is the details. Any question on that?
Question.
Yes, please.
I'm asking if those condition of bone marrow like hypoplastic can be reversed.
Yeah, bone marrow hypoplastic, we can say aplastic anemia can be, some condition may be reversed, but only it depends on the causes. Let's say someone is taking chloramphenicol. Chloramphenicol can induce bone marrow aplasia. So when you stop the agent which is affecting the production, when the factor is removed, the bone marrow can come over.
Okay, thank you.
You're welcome. But in a few conditions, condition may not be reversible. If it is somehow genetic and something like that, it may not be easy to recover from it. Yes, just to recapitulate, so now we are going to erythropoiesis. By erythropoiesis, you should understand that there is a process of producing red blood, how the red blood cells are produced. We have said that in human adult, it occurs in the bone marrow, which we call medullary erythropoiesis, but it may also occur in outside the bone marrow, which we call extramedullary erythropoiesis, mostly in case of myelofibrosis. Myelofibrosis means that the bone marrow is now becoming fibrotic, either due to excess of cell production or in either any causes of myelofibrosis, which may be primary without any clear causes. We have the site of erythropoiesis. We have said about the yolk sac in early fetus, but also from the third and fourth month, we have said about the liver. In the fetus from 20 weeks, the bone marrow will take over up to the puberty and post-puberty. We have explained what is the fatty marrow and the red marrow. We have seen the difference. Then we have the area which are rich in red cell production. We have the ribs, we have the sternum, the vertebra, the pelvis. You remember, if you remember that image I've shown you. We have also described the different cell, like the stem cell, which are the pluripotent hematopoietic stem cells, which has the capacity of producing all hematopoietic cells. We have proerythroblasts starting from the beginning. Proerythroblasts will become basophilic normoblasts, which will have 4 cell division and 16 ductal cells. We have a polychromatic, orthochromatic, and we have seen how the reticulocytes come and mature red cells. With this, we have just trying to describe each of the cell description. We have a proerythroblast. It is large cells and nucleus. It immediately basophilic staining. We have basophilic, which has a basophilic staining due to large number of ribosome producing hemoglobin. We have polychromatic, which becomes smaller and nucleus becomes smaller. And the nucleus also becoming very big because there's increased amount of hemoglobin. We have orthochromatic, which will be the stage of releasing the nucleus becoming neutrophil, becoming reticulocytes, which we no longer have a nucleus, but we have RNA still able to produce hemoglobin. So reticulocyte again spend 1 to 2 days becoming mature neutrophils, mature erythrocytes, which will spend 120 days circulating. This is in summary the image we have from the cycle of the red cell production. You see the images, just recapitulating what you have said. So now, by understanding the control of erythropoiesis, when you are dealing with case of anemia or decreased red cell, you'll understand the mechanism. You will try to relate to your patients what can be the cause of anemia in this condition. So first of all, we have, say, immoral regulation. We have erythropoiesis, erythropoietin producing 90% in peritubular endothelial cell in the kidney, but 10% in the liver. It's usually induced when there is a hypoxia as response to hypoxia. So the action of erythropoietin to usually increase RNA and DNA turnover in hematopoietic stem cell. As you know, those cells make a division and so on. So it plays this role. It stimulates autoerythroid progenitor cell proliferation. It also stimulates the ion uptake by the progenitor cells. It also stimulates hemoglobin synthesis in progenitor cell, but also it reduces the red cell maturation time. So this is globally what erythropoietin do in general. That's make the initiation of erythropoiesis. In normal adult produce 200 billion of red blood cell per day, meaning that If you don't have any related condition, you can bleed today and tomorrow you see how the bone marrow itself trying to compensate the loss of the blood, except if it is massive or uncontrolled bleeding. So how is it regulation? You have done physiology on that, just a quick revision, or it's usually induced by when there is a decreased oxygen supply to the tissue. There will be stimulation of erythropoietin production. The erythropoietin, by playing the role mentioned above, will increase erythrocyte production. That will make hemoglobin to increase oxygen supply to the kidney. Then when the kidney is enoughly receiving oxygen, actually we say, okay, now it's enough. There will be a negative feedback on oxygen saturated on the kidney that will decrease the erythropoietin production. So when there is a chronic activation of this mechanism, that will cause the individual to have extramedullary erythropoiesis. So who can tell us a condition that make the patient to have chronic activation of this mechanism? Just an example of a condition causing in chronic activation of this mechanism. Just a guess. Any example?
Any inflammation.
Sorry?
I said any inflammation can cause overproduction.
No, inflammation, the activation of process I'm saying, we have seen that erythropoietin is produced when there is hypoxia, poor delivery of oxygen to the tissue, because oxygen is, hemoglobin is transporting oxygen, right? Then the mechanism of erythropoietin is really regulated when there is a hypoxia to the renal cell, so it stimulates it to produce erythropoietin. So when the renal area is getting enough oxygen, it causes a negative feedback to decrease the production of erythropoietin. So my question is, in which condition you may see the production of erythropoietin keep on going without any negative feedback?
In a sickle cell disease.
Sickle cell disease?
Yes.
How?
It's because in the sickle cell disease, the lifespan of hemoglobin or white red blood cell is not normal as the normal red blood cell, because the normal red blood cell lifespan goes up to 120 days, while sickle cell disease is less than 40 days. So, in the short lifespan of sickle cell, uh, blood cells lead to overproduction of erythrocytes without negative feedback from the kidney. Thank you.
So in summary, the activation of this system it's seen in a condition which may cause chronic hypoxia. Chronic hypoxia can be seen in case of chronic cyanogenic heart diseases or chronic respiratory diseases which may cause hypoxia. So people with severe heart diseases causing cyanogenic heart disease may have increase of erythropoietin because they're hypoxic for a long time. Then there will be increased erythropoietin production causing increased red cell production. So you may see those patients having high number of hemoglobin, high number of red blood cells because erythropoietin is in overproduction. Is it clear? Because there is chronic hypoxia. That makes sense? Do you understand the mechanism?
Yes, it's
Yeah.
understandable.
Okay, so apart the erythropoietin, we have other micro elements, micronutrients like iron, cobalt, zinc, copper, manganese. For the vitamins, we have especially vitamin B12, folic acid, vitamin B6, vitamin E, thiamine, and so on. Then you have androgen and thyroxine and other amino acids. So again, anemia can be due to either other for this mechanism involving either a decrease in iron, decrease in vitamin B12 or folic acid. So among these, the big one to be affecting the cell production are mostly iron, vitamin B12, folic acid, and thyroxine, which is a thyroid hormone. So after we have said that the normal lifespan of red blood cells is 120 days. After these 120 days, the cell which are old are phagocyted by the reticuloendothelial cells in the macrophage and the spleen in the liver. So what will be going? Hemoglobin will be broken into hem and globin. Hem will be destroyed in iron, and iron will be taken by the transferrin. Transferrin will transport again that iron to the bone marrow for erythropoiesis. The globin will be again destroyed, becoming amino acid. Then that amino acid will be also reutilized. So what does it mean? It means that the iron from the erythropoiesis after the cell destruction, the iron will be taken by the transfer and come back again for erythropoiesis. It's not lost. Then we have the amino acid, which is also used. So what are the clinical conditions where we can use erythropoietin? It's usually anemia of chronic renal failure, because in renal failure, the individual is not able to produce erythropoietin. So in renal failure, chronic renal failure, you use erythropoietin. In the case of autologous blood transfusion is like an example. If I have a planned surgery which is not an urgent, in like let's say I want to get my surgery in December, for example. Today, maybe my surgery may put me at risk of bleeding with loss of blood, massive blood loss. I can go today to the blood bank. They collect my blood. They keep it for me. When I go to the surgery, they use my own blood, not transfuse me blood from another donor. So anemia of chronic disease, why we use erythropoietin? Because in anemia of chronic diseases, it's usually due to inflammation, infection. So when there is inflammation, there will be increased cytokine. So the cytokine decrease the erythropoietin production. So that's one you can also use erythropoietin. Anemia in case of malignancy, or anemia where people are on chemotherapy due to any cancer, anemia due to HIV, AIDS, where there's also cytokine, decreased erythropoietin production, and so on. But also anemia after, no, you can also use erythropoietin after bone marrow transplantation, where the patient gets the bone marrow from a donor. You want to stimulate the bone marrow to produce again, so you can give the patient erythropoietin. So this is the red cell. We have said that the central pala occupy 1/3 of the cell. That was when the nucleus was. Here in this image, you see how the cells are smaller, larger. They don't have the same size. We call it anisocytosis. Anisocytosis means variation in red cell size. You see the small one, you see the big one. Then poikilocytosis mean variation in shape. You see that as different shape. The one here compared to this one, they all have different shapes. So this is poikilocytosis. Now, hematocrit is the packed red cell volume, the percentage of the total volume occupied by the red blood cells. So when they say hematocrit, remember that one. We have mean conspicuous volume, which indicate the weight of hemoglobin in a single red blood cell. So that is MCH. We have MCV, which indicate the volume in cubic or micron occupied by an average single red blood cells. So the rest is given by the machine. Then how do we calculate these red cell indices? Mostly it's given by the machine. What you need to know, you need to know the normal values. MCV, which is in adult 108 to 100. In newborn, it's somehow higher. This is per age. You can see that we have MCH, hemoglobin concentration per cells. So it's the normal range is here. Yeah, the orange should also understand that because it helps you to know when you are dealing with microcytic anemia or macrocytic. Microcytic means you have decreased MCV value, so it's below the normal. It's small size red cells. If it is normal size, we call it normocytic. If it is a large cell, we call it macrocytic. So this should be clearly known, as we'll be repeating that terminology most of the time. So MCHC, which is the mean corpuscular hemoglobin concentration, which is the average concentration of hemoglobin per total red blood cells. MCH was hemoglobin per each cells, but now it is by total red blood cells. This one also help you to know the concentration of hemoglobin. There is another thing we call it red cell distribution width, which really when it is elevated, it describe you the anisocytosis. It means that LDH, the LDW measure the variation in size in hemoglobin in red cells. So if you have a smaller, larger, too much the variation, that will be reflected by increased RDW. Then the normal range is between 11.5 to 14.5. So that is end of the presentation on the red cells erythropoiesis, and you should also understand this terminology before we go to anemia. For anemia, we have different type of anemia. I will share with you the notes, but I'll go straight to the anemia in general, but you'll see the details in the note where we see let me project anemia. Well, let's continue to the anemia. By definition, anemia is just the number, the no decrease in hemoglobin or hematocrit. You consider the age and the gender of your patient, because when you go to a newborn, it's different from an adult. Then female and male, again, consider those parameters. So this table summarizes the normal values for red blood cell, hemoglobin, hematocrit, and the red cell indices, the platelet, and so on. So you go through this, you compare the males, the age of the patient, you see it for each parameters. So for anemia, we have by definition, this is the definition according to the WHO, where we talk about anemia in female when the hemoglobin is below 12 gram per deciliter. Normal range is between 12 to 16 in female. Then in male, it's between 13 to 17. That is the definition. Then you have to classify anemia according to the red cell indices. Normocytic anemia, meaning that the cells are having a normal MCV. The size is normal. Macrocytic, increase size, increase MCV. Microcytic, decrease size, decrease MCV. Then the pathophysiology may be either there's decreased production or there's increased destruction. So most of anemia either due to decreased production or increased destruction. So when you are evaluating your anemia, you should be considering some tests to be done. We have the full blood count, which will give you all the parameters, MCV, hemoglobin, hematocrit. Now, the first thing is to see my patient is having anemia. What next? We go to peripheral blood smear. Peripheral blood smear will give you on the machine, on the smear, you look on the microscope, do you see the realities? You look on the red cell morphology. Is it small red cell? Is it a large one? Is it a normal one? Is it a normocytic or is it a macrocytic? Is it a microcytic? Or it's normochromic, meaning that the concentration in hemoglobin is okay, or it's a hypochromic, meaning the concentration of hemoglobin is reduced, or hyperchromic, increased excess. So those are the things to consider. But also peripheral blood cells should make you to see if there's any malaria, if the platelets are in a good number, if the white cells are okay, they are all mature or normal. So that gives you the overall overview of things. Then you go also to check for the reticulocyte count. Reticulocytes reflect the index of cell production from the bone marrow. Any ineffective production of the cell from the bone marrow will be reflected by decreased reticulocyte production. If the problem is due to increased destruction, what will be going when there's increased destruction? The bone marrow is trying to compensate the loss of the cells by increasing cell production, which will be reflected by increased reticulocyte count. That should be the element to consider. So the automated machine, it's usually the one we have in the laboratory. I think we have do your rotation in hematology, where you have seen the machine, the automated machine there. It give you everything. As I said before, they used to do it manually counting, but now everything is produced there. You can get the red cell parameters, the white cell counts, hemoglobin, hematocrit, platelet count. Some specific machine will also give you the reticulocyte count. Then you go to the interpretation and description of cell morphology. So sometimes the automated machine may also give you some details about the size, but it's also good to look on the machine, on the peripheral blood, to look how what the machine is saying, if it is correct or not. I've shown you how to calculate MCV. We have said about red cell distribution with which measure the rate of variation in size. We have discussed about that. Now let's go to peripheral blood film. So when you request for peripheral blood film, it diagnostic on many conditions. It also give you an idea about which test to request next. Then it also help you to confirm what you see on the automated machine. As I said, let's say people may have platelet clamps in the ADTA tube. The automated machine may count that the platelet is few, but when you go to the machine on the peripheral blood film, that's when you realize that the platelets are clamped together. The machine cannot count those platelets. So it helps you to exclude if there's no platelet clamps. So how the smear is done, I think you have an idea from the laboratory. You do the smear, you take a 2 slide and you make a slide. I don't have to explain it on now. Then you look on the microscope. This is here on the arrow. It is a small lymphocyte. Normally, the size of a normal erythrocyte is comparable to small lymphocyte like this. Now, the estimation of saying that is it a smaller or a larger one, it's really to compare with the size of a small lymphocyte. So what is the role of peripheral smear? It's usually to assess the red cell morphology, to confirm if it's really thrombocytopenia or it's now somehow clamp of the platelet together. It also helps you to see the abnormal cells. I said that in peripheral blood, you in normal condition, you are not supposed to see immature cells. So the precursor cells, so all cells should be mature in normal condition. You can also see some infection like malaria, babesia, microfilaria, and so on. You may also see in case of hypofunctioning of the spleen, some inclusion in the cell like Golgi bodies. Those are the abnormal red cells which are supposed to be removed by the spleen. But if the spleen is not there, those cells will be circulating. So that's when you see it, maybe in this showing you that the spleen is hypofunctioning. So when you are doing to get this peripheral blood film, you need to have to do phlebotomy using ADTA anticoagulant. Then the smear should be done within 1 hour to prevent platelet clumping and any other artifacts. You may not need to stain it immediately, but you keep them, you keep the slide and so on. Then when you are looking on the microscope, you may test that by 10 view, going up to see the cell distribution, area of selection. You go to 40 times, then 100 times, where you can see more details about the cell description. So this is the red cell, which is normocytic, normochromic. The central area you see here should be 1/3 of the cells. They are somehow closer to the small lymphocytes, so those are normocytic, normochromic. Then this is a neutrophil, it's a lymphocyte here. Then you have platelet here. In the case of platelet clamps, that's how the platelets come together in one region, a lot of platelets in some region. Ichoge machine may not count it as the normal now. We have reticulocytes, which are huge cell compared to the normal red cells, meaning that when there is increased reticulocytes, there will be tendency to have macrocyte. Red cell end cells will be larger because there is increased reticulocyte. So we say that spend 1 to 2 days and they are destroyed. They are macrocytes. They are huge compared to the normal cells. So how is the reticulocyte reporting? We have normal reticulocyte, which should be 1 to 2%. But when you calculate it, you take the number of reticulocytes calculated, you divide it by the number of total red blood cells, and you multiply it by 100. Absolute number is between 50 to 70. Then there is a formula to get absolute reticulocyte count, which really take the reticulocyte count, you multiply it by red blood cells, and you multiply it by 10. So this is really the one reflecting the cell production from the bone marrow. And then here you see the peripheral blood film. This is reticulocytes. They are, you don't see they are larger. Then you don't see the basophilic. You don't see the central pala in the center. So in some of the condition, you have hemophilia. We have hemolytic anemia due to cold agglutinin, which means we have cold antibodies making the red cell to be destroyed, to destroy themselves against the antibody destroying the red cells. So there will be agglutination of the red cell. So if someone is having red cell agglutination, you see the red cell clamping together like this one. So that one you shock. It make you to know really there is a cloud agglutinin. We have also, in case of multiple myeloma, red cell coming together like a rouleau. You see the rouleau here. When you see rouleau in the second images, you can be sure that I'm having a rouleau. What are the conditions that may cause rouleau? We have uh, multiple myeloma and so on. So again, you will see poikilocytosis. Remember, poikilocytosis mean variation in shape. So you may see elliptocytes, spherocytes, and so on. So this is elliptocyte. You see the image like ellipse. That's why they call it elliptocyte. So erythrocytes, those are the red cell have defect in alpha and beta spectrin, which are the red cell membrane protein. When they miss those spectrin, they are fragilized and they can be destroyed easily. So patients will have hemolytic anemia due to erythrocytosis. Just because the membrane cannot resist in the 120 days, they are destroyed earlier. So the incidence is not known, but it is around around 5 in 10,000 population in US. We have in Africa 2,000 per 10,000. We may have spherocytic erythrocytosis. We can also have common erythrocytosis. Then we have also defect in the membrane. We have also hereditary spherocytosis. We have here again, there will be actinin and spectrin deficiency causing the cell to be small like this. You see how the small are smaller? They don't have the centropella. Then they are somehow hyperchromatic like this. They have increased amount of hemoglobin. So they are hyperchromic and smaller like spherocytes. So these are hereditary spherocytosis, which is again autosomal dominant. They are really exposure to have hemolysis before the normal lifespan. Sickle cell anemia, remember in the pathophysiology, we have on the beta chain of hemoglobin, genetic, glutamic acid is replaced by the valine in that position. So there'll be change in red cell morphology becoming a sickle-shaped. So sickle-shaped cell lose the elasticity, and by losing the elasticity, they could not move through the bloodstream, and they can clap, they can make obstruction of the vessels, causing vaso-occlusion on the vessels. That will be the pathophysiology of the sickle cell crisis. So this is how you can see sickle-shaped cell in the peripheral blood film. So here I'm just showing you what is the role of of the peripheral blood film, where you may see different morphology by requesting peripheral blood film. Here in the image, what do you see? On the first image, maybe it's smaller, but you can see. What did you see on the image? You see, when you look at the small lymphocyte, you see that the cells are smaller compared to the small lymphocyte. Then the central pala, we said that it's occupy 1/3 of the cells, but now it's huge. So this is an hypochromic microcytic red cells, which is usually seen in which condition? Who can tell us? Microcytic hypochromic anemia is seen in which condition?
Iron deficiency.
So iron deficiency is the leading cause of microcytic hypochromic anemia, followed by the beta thalassemia and so on. So you see the size is small and they are hypochromic, less hemoglobin concentration. Then the second table is for thalassemia. In thalassemia, what we see decrease size, but there's something we are seeing in the centrum. Instead, in the centrum, where you see something called target cells. Those are the image in the center, a point on the center there that's called target cells. So another condition which is you may see on the peripheral blood film, it's what we call macrocytic. The cells are bigger. They might be bigger and ovalocytes, like ovalocyte morphology, or can be bigger but round. So we have macro-ovalocytes, which is seen in megaloblastic anemia. Megaloblastic anemia is usually due to deficiency either in folic acid or in vitamin B12. Then round ovalocytes may be seen in liver disease, alcohol, and so on. We have also increase of reticulocytes. We see the reticulocyte is larger. You may also see it in case of myelodysplastic syndrome. Myelodysplastic syndrome meaning that the bone marrow is failing to produce normal cells, meaning either morphologically or in number. So those are the myelodysplasia cells. So cause of macrocytic anemia, meaning that now the cells are larger compared to the normal one. The MCV is between 80 to 100. Now you find the MCV of 120. So what are the causes? We have megaloblastic anemia. We have myeloproliferative disorder or myelodysplasia. Myeloproliferative, if I say myeloproliferative, understand any condition which may cause increase in myeloid cell production. Either it can be leukemias, it can be essential thrombocythemia, increase in platelets, or increase in red cell in case of polycythemia rubra. We come up to this condition. We may have liver diseases, hypothyroidism, and so on. So let's now discuss about megaloblastic anemia, which is megaloblastosis. So megaloblastic anemia, it usually, as I said, due to deficiency either in folic acid production, in folic acid or vitamin B12. So folic acid and vitamin B12 come in the synthesis of DNA by transforming nuclear synthesis of DNA by transforming homocysteine to methionine. Remember that DNA synthesis process. So those are the two playing that role. So there'll be a disorder of DNA synthesis that lead to nuclear cytoplasmic maturation asynchronia, and which is a characteristic morphologies of the changes. So when I say nucleocytoplasm maturation asynchronia, meaning that when the cells are maturating, they maturate at the same time. Nucleus and cytoplasmic maturating at the same time. But when there is asynchronia, you may see a nucleus at different stage of maturation. So mostly the nucleus, it may be on the case of polychromatic erythroblast. Ikawa fit the nucleus here, orthochromatic nucleus. So the nucleus and the cytoplasm are not maturating in the same times. So that is the key component to see when there is a megaloblastic anemia. So what the cells will be having macroovalocytes, so they are huge. They have hypersegmented neutrophils. Normally, neutrophil has 2 to 5 lobes, but in the case of vitamin B12 or folic acid, you see the neutrophil may have even 7 lobes. You can see in the image. They may also have fragmented red blood cells. They may also have jolly bodies, and they may also have what we call carbot ring, which is inside here. We call it carbot ring. Those are just the malformation you can see on that. So the disease is usually due to vitamin B12 or folic acid deficiency. Vitamin B12 is also called cobalamin deficiency or folate deficiency. Apart having the 2 vitamin deficiency, but to also consider any medication which may interfere with the DNA synthesis. So we have medication like 5-fluorouracil, which is given in case of leukemia or cancers. We have azathioprine, we have hydroxyurea, zidovizine, and some of anticonvulsants. So this is again things which interfere with the DNA synthesis. Other condition may interfere with the DNA synthesis. We have orotic aciduria, thiamine response megaloblastic anemia, and Leschner syndrome. Again, those are the condition. Again, the mechanism beyond this, it's just interfering with the DNA synthesis. So when there is a issue with the DNA synthesis, the cells took longer to make division. They make division where they're already huge in size. So that make the cell to maturate by having again huge size. So that's just a calculating imaging showing the role of either cobalamin or folate deficiency as they participate in the synthesis of DNA by transforming homocysteine to methionine. So what will be happening when the deficiency either in vitamin B12 or folic acid deficiency, there will be this mechanism will be decreased or inhibited, so there will be tendency to have increase of homocysteine. Homocysteine, when it is increased in the body, it may also cause risk of developing deep venous thrombosis. So remember, if you have someone with a deep venous thrombosis, remember to screen for vitamin B12 deficiency or for folic acid deficiency. We go to megaloblastic erythropoiesis. Again, when you look on this nucleus, there is a ansynchrony between the nucleus and the cytoplasm. This should be a nucleus of any advanced maturation, but still the nucleus is in the previous stage of maturation. What else they have in the bone marrow? They have what we call giant bands. Band, it is just the maturation stage which is beyond the neutrophil. From the band to when you have segmented neutrophil. So you will see large band, giant band in the bone marrow. We have also megaloblastic anemia in case of platelets. Megakaryocyte, this is a megakaryocyte. When you see here, in case of megaloblastic anemia, you see also there's also change in the megaloblastic in platelets formation. So what we have as a investigation in the case of someone with vitamin B12 or folic acid deficiency in the case of megaloblastic anemia. So in the beginning, the patient may present only anemia, but later on, they have increase of MCV, increase of red cell distribution. They have low reticulocyte count. There will be increase of LDH, increase of bilirubin, decrease of aptoglobin, increase of iron and ferritin. Who can explain the mechanism behind this test elevation? Why do them have increase of LDH, bilirubin, and decrease of aptoglobin? Anyone can try? Anyone trying that?
Can you please repeat the question?
So my question is, why does a case of decrease or deficiency in folic acid or vitamin B12 may cause increase of LDH, increase of bilirubin, decrease of aptoglobin? Iron and ferritin are increased. Why do you think that? Hmm?
I can try.
I'm listening. Why?
The reason behind is we are having increased LDH. We are having increased LDH because we are having hemolysis.
Hmm?
We are having increased LDH because we are having hemolysis.
Where?
And also, we are having the increased, no, decreased hepatoglobin because of the hemolysis, the hepatoglobin is going to be decreased because it's the one that is responsible for catching the hemoglobin, which is the reason because of the hemolysis.
Yeah, that's a good answer. So those patients have intramedullary hemolysis, so which is different from the normal hemolysis. The megaloblastic red cell abnormal cells, they are destroyed in the bone marrow. So they have intramedullary hemolysis. So that's why they may also present like hemolytic anemia, but yes, their site of hemolysis is in the bone marrow. So that is why they have a future of hemolysis also. So sickle cell, we have seen it. Those are exercise. Maybe we need to job. So we have also folate deficiency. Folate is found mostly in the plant sources. We have the average daily requirement of M 150 microgram. Their storage is about 10 to 12 milligram, which may protect someone up to 4 months. The absorption and everything is usually on the jejunum, where they're absorbed. You can also see the intrahepatic and so on from the stomach, and the detail is there. The cause of folate deficiency may be due to poor dietary intake. If you're not getting enough from the vegetables, you may have it. Again, what we can say here, it's just when you cook more your vegetables, you decrease the amount of folic acid. So it's better to eat vegetables which are not cooked deeply, or not cooked very much. We have also in the case of the increase in demand, increased demand, for example, in the case of hemolysis, if someone is hemolyzing, so there is a increased cell production from the bone marrow where there will be overuse of folic acid. So if you don't supplement the patient with that folic acid, he may develop folic acid deficiency. You may also have intestinal malabsorption. We may also have defective utilization of folate in case of medication. We may also have folate antagonists in case of methotrexate, metformin, and so on. That's why when you are suspecting folic acid deficiency, you should also ask the patient about the medication taken, ongoing medication. So how do you make the diagnosis? It's just by measuring the folic acid in the blood. And if it is normal, you should also check for vitamin B12. You may also find increase of homocysteine. We have shown the mechanism how homocysteine may be increased. So how do you treat it? We have to take it 1 to 5 milligram daily for 4 months. Then you make a follow-up. Then remember, in case of demand, in case of pregnancy, where we are preventing some malformation, the baby like spina bifida, you have to give folic acid. You have to supplement in case of hemolysis, which is chronic hemolysis. Again, in case of hemolysis, the patient may develop rapidly cytopenia due to folic acid deficiency. It may be associated with a narrow tube defect. Again, that's why it's better to supplement even pregnant women. But even before the pregnancy, someone who's planning to get pregnant should be starting taking folic acid before the pregnancy. In adults, having neurological manifestation is rare. So we have the laboratory will show elevated in homocysteine, but when someone is getting having neurological manifestation in case of cobalamin deficiency, where we see giving folic acid may worsening the condition. So the condition of vitamin B12 deficiency, maybe I can jump before going to vitamin B12 deficiency. Vitamin B12, apart playing the role in the synthesis of DNA by transforming homocysteine to methionine, it also play role in the lipid metabolism by converting methylmalonic acid to succinyl coenzyme A. So again, if you want to detect early the deficiency in vitamin B12, you may also test methylmalonic acid, and you may find that it will be increased. So increase of methylmalonic acid may be found in case of vitamin B12 deficiency, as it also play role in the metabolism of lipids. So what is going on the vitamin B12, which is a cobalamin? Cobalamin from the food we eat, it bind to the air protein, which is produced by the pancreas. But at the stomach, at the parietal cells, there is a production of intrinsic factor. The intrinsic factor is the one facilitating the bind of cobalamin to intrinsic factor. So intrinsic factor cobalamin will be the one to facilitate the absorption of the vitamin B12, which is really done in the area of duodenum, jejunum, and ileum. So again, any issues interfering with the absorption of vitamin B12 may from the pancreas, the stomach, the intestinal area will affect especially the intrinsic factor, which is mostly involved in the absorption of vitamin B12. So let's go back to pernicious anemia, which was first described by Thomas Addison in 1885. It is called pernicious anemia because it was fatal. It mostly affects Northern European ascetics. They have no gastric secretion of chloride hydroxide. So those patients has high risk of gastric CA and carcinoid. So they have antibodies to intersect factor. So the intersect factor are produced by they're destroyed by the antibodies. So they have antibodies for intersect factor. Then they may have also presenting future for tropical sprue, and there are other differential diagnosis may be also the same person describe may have a paroxysmal nocturnal hemoglobininuria. We have this, we may see it in other topical aplastic anemia, spherocytosis, and sickle cell anemia. So let's go back now. When someone is having pernicious anemia, how do you treat it, and so on? We discuss it more down here. So the slide are somehow mixed up, but they have a chronological. So things we have to understand, it's about how many, how is the storage of each element, and for how long the storage will keep us. So day loss of cobalamin is 1 microgram, but in case of malabsorption, you may lose 2 microgram. Then the absorption from the oral doses, if you take 1 microgram, if it's normal condition, you get 0.56. If you have malabsorption, it's really very little of cobalamin which should be absorbed. So this is just comparing in normal condition what you have and someone with malabsorption what you have. So that's why people with malabsorption, we prefer to give them intramuscularly instead of giving the tablets. Uh, for pernicious anemia, again, we have it is an autoimmune gastritis. So the Pareto cell are destroyed by as an autoimmune diseases. There will be anti-Pareto cell and anti-intercept antibody production, which will be decrease the Pareto cell function. There will be achlorhydria, but also decrease intercept factor production, also decrease cobalamin absorption. So what are the manifestation of deficiency in folic acid and in vitamin B12? We have the patient will have symptom of anemia in general, but also they may have paleness, lemon yellow skin, because as I said, they have hemolytic anemia, they have intramedullary hemolytic anemia. Adding this, they may also have a neuropsychiatric symptom. They may have a paresthesia, dementia, psychosis. There are some people come with the behavior changes, ataxia, weakness, or spasticity. So there, we have seen also patients come with paralysis of the lower limbs due to severe deficiency in the vitamin B12. So other manifestation, they have glossitis or other epithelial changes. As it's an autoimmune disease, they may also have association with other autoimmune diseases like having hypothyroidism, vitiligo, and diabetes. Again, they have increased risk of gastric cancer or carcinoids. So how do you make the diagnosis of that? You may measure the anti-intercept antibody, which will be positive. You may also measure the parental cell antibodies, which will be positive in 80 to 90% of patients. It has low specificity, but also there will be increased gastrin secretion. So again, it's among the key things to measure when you have suspicion of pernicious anemia. So this is just the comparison between deficiency in cobalamin and in folate. So when you have deficiency of both, you will have plasma increase in homocysteine because they all interfere with the conversion of homocysteine to methionine. But for cobalamin, they'll have increase of methylmalonic, it will be increased. Then in case of folic acid, it will be normal. Then you should also measure the cobalamin and the folic acid level separately. So what we have as to treatment, the treatment is given by hydroxycobalamin or cyanocobalamin. For people with malabsorption, the medication is given by intramuscularly because they cannot have a good absorption of that, especially in case of pernicious anemia. The dose is around 1,000 microgram, but you have to keep the patient over and over the follow-up because the malabsorption is there because of the pernicious anemia. It's like a lifelong treatment. So they may also cause neuropathies characterized by the posterior and lateral column involvement. So those are just describing how the deficiency of vitamin B12 can cause neurological manifestation. So they may have disintegration of myelin and loss of axon and so on. So you may see it better in neurology course. So remember again the medicine we have talked about, which may also interfere with the folate metabolism and so on. So what we need to understand also, it's to know what is the we have said that the deficiency in folic acid usually in plants, vegetables. But what about vitamin B12? Vitamin B12, it's usually purely animal protein. You don't find it in the fruit, you don't find it in the vegetables. So the question to ask your patient is about uh, do you eat animal protein? He say yes, but the question is how frequent do you eat it? So I may eat meat once in a year, but asking the question, do you eat this is not appropriate. So ask to a patient, how frequent do you eat this? So the patient will tell you, I'm a vegetarian, or so depending on the response of the patient, you understand that the deficiency is either due to poor diet or it's just due to malabsorption issue or other thing related to that. Any question about vitamin B12 and folic acid? If I say, what is the treatment of vitamin B12, how do you want to reply? How do you treat vitamin B12 deficiency? If you understand what I've said. So you give a cobalamin orally for how long? So how do you treat folic acid? So folic acid, I said you give it 5 milligram for 3 months. If it is an issue due to nutritional deficiency, you have to advise the patient to adjust the diet, and you make follow-up. If it is a patient with malabsorption, the treatment will be lifelong. So ask the patient about any surgery on the GI interfering with the malabsorption. So that's one. So for the vitamin B12 deficiency, remember what is the causes. It either be issue due to diet. In that case, you treat the vitamin B12. Normally, we give intramuscularly for 7 days. Then after 7 days, we give it once a week for 4 weeks. After 4 weeks, we give it once a month for 3 months. Then you stop. Patients should be adjusting the diet. So if the patient is now not able to adjust the diet to eat animal protein, you advise the patient to keep getting a weekly dose of oral vitamin B12 cyangwa se akasimplementinga whatever is eating. We have some supplemented farine on the market which contain vitamin B12 as fortified. But if the patient is having pernicious anemia, meaning that the intestinal factor is now not a decrease in production as we have autoimmune diseases destroying the parental cell, which is not able to produce intrinsic factor. What will be the treatment? The treatment is to give now intramuscular. If the patient is not having malabsorption, you may take the tablet, but people with pernicious anemia, you give it intramuscularly again once a day for 7 days. After 7 days, one weekly for 4 weeks. After 4 weeks, the patient will keep once monthly for life. So that is how you treat pernicious anemia. Ariko uwundi muntu uyifite just for diet issues, try him to adjust the diet. If not able to be, niba ashaka kuguma vegetarian, I need supplement tablet orally for every time. Yeah. Any question or was it clear? So if it was clear, let's go now to iron deficiency. For iron deficiency, I want to insist on a few things. Let's discuss about microcytic hypochromic anemia, which is the iron deficiency is the commonest cause of microcytic hypochromic anemia worldwide. It's anemia which is represented by decrease of hemoglobin, MCH and MCHC. Microcytic mean that the side is small, and hypochromic mean that is pale, decrease hemoglobin concentration. The differential diagnosis of microcytic hypochromic anemia, apart being the iron deficiency, we have anemia of chronic disease, you have thalassemia, and you have sideroblastic anemia. We will go in details on that later. So remember the chain of hemoglobin, you have alpha and beta chains, and we have iron atom on each hemoglobin chains. So each red cell blood produces 640 million of hemoglobin molecules. We have adult hemoglobin, which contain 2 alpha and 2 beta chains. And the molecular weight of hemoglobin is 68,000. So we consider also normal hemoglobin, which normal adult hemoglobin, which contain small quantity of hemoglobin, fetal hemoglobin, and hemoglobin A2. So which also have some different chains there. So again, this is iron containing hem, and we see how iron is very important in hemoglobin components. So what is the function of iron? It is oxygen binding, hemoglobin and myoglobin. It also plays a role in the cytochrome and coenzymes by conversion of a ribosome to deoxyribosome nucleotides, which is necessary to the DNA replication and cell divisions, but also it plays a role in the transforming electron from some reaction like which also have participate in the redox reaction by converting ferrous ion to ferric ion, which is more absorbed in the body. So ion deficiency also have a mechanism. It we have if there is a ion deficiency here, we have deficiency in ion incorporation in the M molecule. It may be seen in case of iron deficiency, chronic inflammation, or malignancy, where the iron cannot incorporate in the erythropoiesis. We also have a deficiency in porphyrin, meaning that, for example, in case of sideroblastic anemia, iron is there but cannot be incorporated in the mitochondrium of the precursor cells. So the iron will stay outside of the mitochondrium, not able to make the synthesis of hemoglobin. Then when you have deficiency in globin chains, we have either alpha or beta thalassemia. So these are the conditions which may cause the red cell to be small in size. So list of the differentials, you have MCV will be decreased. This is the list of the conditions which may cause microcytic anemia on the top, iron deficiency, and the rest. You can see on the image where we have a small size of the red cells. How is the diet? Each diet we eat contain like 10 to 2 milligram of iron. The absorption is like 10%. We get only 1 to 2 milligram per day at the duodenum and the upper jejunum. So these are the elements of diet which contain more iron. That's why I say again, when you're asking your patient, you should be also knowing the diet the patient is taking. So rich iron item contain liver, egg yolk, meat, beans, dry fruit, and so on. Medium are like this, meat, chicken. Poor, consider cow milk, root vegetables. So when you have a baby above 6 months, just drinking cow milk, that baby will be exposed to develop iron deficiency if he's not having other foods to complement what he's eating. So poor milk, cow milk has poor amount of iron. So this is just pictures of what we have said. And from the absorption from the diet we get, the absorption is there, only 1 to 2 milligram. 75% will go to erythropoiesis. 10 to 20% will go for ferritin as a reserve storage. Then 5 to 15 will go to other process. Then the day loss is around 1 to 2 milligram from desquamation of epithelium. What does it mean? Meaning that there is no physiological mechanism to excrete iron which is there. So we have said about all this. The storage of iron, it is around 3 to 5 grams. There is no physical excretion mechanism. We have seen that. But just let's talk about iron absorption. So iron absorption is enhanced by M ion. M ion are the one coming from the animal protein. The non-M ion come from the vegetables like beans, like whatever, spinach, and so on. So M ion will have high absorption. If you take iron with ascorbic acid, that will increase the absorption. But also when you take ferrous ion, again, that's why on the market they are now producing ferrous iron, not ferric iron, because ferric iron, the absorption is low. What inhibit the absorption? We have cereal, tea, coffee, milk. So calcium containing element like milk. So that's why if you are giving iron to a patient, you have to advise the patient to avoid those inhibiting factors. Don't take it at the same time, at least 2 hours between. If you have to drink milk, take the milk 2 hours after taking your iron. Better to take it with the vitamin C or other things. So requirements, daily iron requirement, we have from 4 months, we have 0.5, we have for children around 5 months, the level is there. Menstruating women, because they get messes every month. When you are losing blood, you are also losing iron. So that's why, again, women in the age of reproduction should be taking amount of iron, which is really very good for them. After menopause, you see that the amount is also decreased at the men, the same. So again, by saying this, you'll see who is at high risk of developing iron deficiency. Just to clarify, M iron and non-M iron, vegetable sources and non and animal sources. Now, if you find your patient with the iron deficiency, you don't need to stop there. You have to go deep and find out what is the cause of this iron deficiency by starting by diet. Ask the patient, do you eat this? How many times do you take this? And we go to the absorption. Example, if someone is having TB, lymphoma, history of gastrectomy, and so on. That's the second question. Third question is about blood loss. We have said that when you lose blood, you are losing iron. For example, 500 mils of iron, when you lose 500 mil of blood, you are losing 250 of iron. Source of bleeding should be assessed. It's either epistaxis, hook arms, any bleeding should be assessed. So remember, chronic bleeding cause iron deficiency. So what is the iron deficiency? So decrease intake, increase requirement, iron availability, limit erythropoiesis, and you have stage of iron deficiency. So first of all, we may have ferritin, where there will be the tissues are depleted. Next, we have reticulocyte store depleted. Then after that, we have anemia, purely microcytic hypochromic anemia. This is how the picture just explained. So who has the high risk of developing iron deficiency have repeated pregnancy in short intervals. Why pregnancy? It's just because in pregnancy there is increased demand of iron. When you don't get enough supplement, you may have high risk of developing iron deficiency. That's why in case of pregnancy, they give systematically iron supplement to each pregnant women. Women of reproductive age group, we have said why, messes. Age group below 55, elderly people, where they have a decreased appetite, they have to choose what to eat. So, and you have institutionalized individuals, for example, people in the school, in the prison, where they are exposed to one kind of the diet. If it's not rich in iron, they may have decrease iron. So what are the future of anemia? Maybe I didn't explain it before. So anemia in general, mechanism of anemia, there will be poor oxygen supply to the tissue, to the organ. That will be represented by easy fatigability, loss of energy, pain, weakness, palpitation if the anemia is severe. Then when you go to physical exam, the key thing to look on the patient is to check the conjunctiva. So conjunctiva pallor is the best sensitivity test to see and specificity to know if the patient is anemic on the conjunctiva, because patient may have pallor on the hands, on the palmoplantar due to other conditions. But when you see conjunctiva pallor, it's really specifically for anemia. If the anemia is severe, that may also have tachycardia, systolic murmur, cardiomegaly, just because of the severity of the anemia and the duration of the anemia. So now we have to also think about the underlying conditions. For iron deficiency, we don't know by which mechanism they have seen cases of what we call koilonychia, which is like change in spoon shape. So the patient may present spoon-shaped nails, angular stomatitis, glossitis. They may also have a change in the neck, the nails. Again, the mechanisms behind this change are not well understood. Either it is a loss of enzyme containing iron, They may also have growth retardation, poor conjunctives. There are some may consult also for a condition called I forget it. So a patient can develop some different tests of eating something which is not eatable. Uh, how do you call that condition? I just forgot it. Ugasanga ari kurya igitaka cyangwa se ari kurya umuceri udatetse ibintu n'ibyo bitari eatable. How do you call it? Anyone knows?
Pica or craving.
Thank you. So the patient may also have pica. She may say, Doctor, I'm now eating like igitaka cyangwa se nkunda kaunga gusa. I can't eat anything except kaunga or something like which is not usual. So they may also develop that. So this is glossitis. You have also koilonychia, which is here, spoon-shaped nails. They have also angular stomatitis. So they may also have a neurological effect like ischemic stroke, platelet leg syndrome, and development again. Again, they may have issue with the neurotransmitter metabolism, increase of oxygen to the brain, and so on. Those are the predicted mechanism. In the laboratory, the key thing to think about iron deficiency, which is the dosage of ferritin. So here they just explain that the table here we have anemia, iron deficiency anemia, anemia of chronic diseases, thalassemia, and sideroblastic anemia. They are comparing each parameter. Of course, all of them, they're anemic. That's why everything is decreased here in hemoglobin. They may have all of them decreased MCV. Here it's normal or decrease. Thalassemia is decreased. Sideroblastic anemia can be decreased or increased. So that's the difference. Then MCH, MCV, Bioseni has microcytic hypochromic anemia. Here you have your normal peripheral blood film. You look on the peripheral blood film, you see a red cell which is normocytic, normochromic. But when you go to the central pala, which occupy 1/3 of the cell. So this is like a normal morphology. The variation is not seen. You see, most of them are somehow in same size. Then this is deficiency anemia, where you see variation in shape, which is poikilocytosis, variation in size, endocytosis, but also small size pala of the central pala is somehow pale, so microcytic hypochromic with anisopoikilocytosis. So that is how you describe these slides. It's typically for iron deficiency. That is the description. When you go to the bone marrow, there will be poor bone marrow, absent iron in the bone marrow, you can see. So Prussian blue is the stain we use to see the amount of the iron in the precursor cells. Then from the precursor cell, you see even the size are already small from the bone marrow cells. Those are the precursor cell. This is a bands here, myelocyte here, bands again here, and so on. Morphology, again, the precursor cells are small in size from the beginning. This is a sideroblastic anemia. Sideroblastic anemia, there is deficiency in enzymatic pathway which incorporates iron in the mitochondrium of the red cell precursors. The ions stay outside of the nucleus. You can see here, those are the granules outside, which has iron. You see it in sideroblastic anemia. So now, how do you make the difference between anemia of chronic diseases and iron deficiency? Because they may present, I said they may have same microcytic hypochromic. So first thing to measure it is iron. Iron will be low in case of iron deficiency anemia, will be low in case of anemia of chronic disease, will be normal or even decrease in case of sideroblastic anemia. That's first thing to do. TIBC, total iron binding capacity, will be increased in iron deficiency, decrease in anemia of chronic disease, and the rest will be normal. Ferritin will be decrease in iron deficiency. Here, anemia of chronic disease is mostly due to inflammatory process. So ferritin is a positive reacted protein, which is supposed to be increased in case of inflammation. So it may be either normal or increased. Normal in thalassemia, but sideroblastic anemia is the iron which is supposed to go for erythropoiesis is not longer used, so there will be increase in ferritin in case of sideroblastic anemia. So transferrin will be increased in case of iron deficiency, normal in case of chronic diseases, variable in thalassemia, and normal in case of sideroblastic anemia. Then you go for bone marrow iron and so on. That is more details. Then when you find your patient with iron deficiency, again, go deep and find the cause. And when you are treating the patient, you have to address the causes. So people who are not in age of hemorrhage and at age of menopause, before the menopause, those are female who may present like heavy menses, bleeding from the genital area. So control if there's no huge massive messes which are large, which are heavy or prolonged, repeated pregnancy. But also for men and the postmenopausal, remember to check for the GI blood loss, if there's any loss of blood, bleeding, and so on. They may need to go for endoscopy, colonoscopy, and so on. You may also need to do a stool exam to check for the OCAT blood tests and parasite. We have some parasite schistosomia causing iron deficiency, so you have to exclude the bleeding from the urine and so on. X-ray to exclude also primary hemosiderosis. So those are the tests to try to get the etiology of iron deficiency. So concerning the management of iron deficiency, first of all, targeting the causes, but meanwhile you are looking for the cause, you need to start the patient on the treatment. You need to give iron therapy by ferrous sulfate, 200 milligram twice a day or twice a day for at least 6 months. The target of the treatment, it's not to raise hemoglobin and stop the treatment. The target is to replenish the storage of iron. So when you are treating your patient, the target is to see how is the ferritin. You treating someone with iron deficiency. If I have hemoglobin of 8 today, you start me on iron deficiency for iron therapy for iron deficiency. Every week, I'll be raising 1 gram per deciliter. So after 4 weeks, I'll be having hemoglobin of 12. So you don't need to stop the treatment because I have a normal hemoglobin, but you have to check my ferritin. Ideally, we should stop the ferritin, the iron, when the ferritin is around 30 milligram. The normal range being 13 to almost 300. So targeting is not only to target the hemoglobin, but to target the storage, but also to address the causes, treat the causes. Otherwise, if you don't treat the causes, the patient will move all over the hospitals looking for treatment of anemia, which should be controlled if the treatment is well addressed. So remember, we have said drinking iron with the enhancing factors like ascorbic acid will be advised. Then the iron should be taken 30 minutes before meal. Avoiding inhibitors of absorption like coffee, tea, calcium, or milk containing elements. Then if you are in the area where you cannot test the response, start by checking your reticulocyte will be increased in 3 to 7 days, and the raise in the hemoglobin level will also help you. unimolecular iron on the market. We have different form. We have ferrous sulfonates, ferrous gluconates, fumarates, and so on. We have a parental to those who have iron malabsorption, or those who may not take iron orally. But all of these brands, there is no scientific evidence which prove that this one is better than another one. So the only element is to consider which amount of iron you are giving to your patients. So depending requirements of iron, when there is a iron deficiency, there is increased absorption, iron storage, ferrous or ferric iron, vitamin C, pH, and chelate of iron. Chelates of iron are those things we have said about it, coffee, tea, and so on, but also malabsorption. This is just a repetition, I think. And therapy 6 months after mobilized in order to complete, you have said it, and treatment of the cause. So that's one I can tell you to. So as I was saying that which iron is the better to give, it is considering the element of iron you are giving to your patient. So on the choice here, the ferrous fumarate is the one containing a lot amount of iron which is somehow higher considered to the other iron. So fumarate iron kuri market tufite iriya Fersefol, maybe you have heard about it. Muri pediatrics, the dose is 4 to 6 milligram per day of iron element. So that is so when you're in an area where you cannot measure iron parameters, you have to give the medicine and think if there's no response, maybe you are giving poor compliance, absorption is not an issue, it's a problem, or you're not treating the wrong diagnosis, or the patient is bleeding. So if the patient is responding, again, it's a good response, consider treating the iron for a long time, because sometimes you may be working in the district hospital where you may not have access to iron parameters. So those are the issues to consider. Yeah, so that was, yes, we have said it. If there's no response, consider other causes of anemia. A little word on anemia of chronic diseases. It again, the one of the most common anemia after the iron deficiency. If you go to the hospital today, you see people who have anemia in the hospital. You see the prevalence of anemia high on this patient. So, what are the mechanisms of anemia of chronic diseases? It's usually due to chronic inflammatory diseases, chronic infection, or malignant diseases. By which mechanism? Normally, this inflammatory process, they are associated with increased cytokine production. So when there is a cytokine production, they have a negative effect on the production of erythropoietin. So by decreasing of erythropoietin, there will be decrease of erythropoiesis, causing anemia. That is one of the mechanisms. Secondly, in case of inflammation, there will be on the liver, there will be increased production of hepcidin. So hepcidin normally will go to the storage site of iron, for example, in the hepatocyte, in the duodenum enterocyte, causing normally from the site of storage, there is another molecule called ferroportin. So ferroportin normally take iron from the storage organ to be bind to the transferrin in the bloodstream. So when there is increase of hepcidin response to inflammation, so the hepcidin will block the effect of ferroportin. So there will be tendency of ions to stay in the storage organs. So by this, you will go, you check the ferritin will be increased, but the iron in the bloodstream will be decreased because there is tendency of iron to stay in the storage organs. Then as there will be decrease in iron in the serum, the transferrin will transport less iron to the site of erythropoiesis. So meaning that the anemia is not due to iron deficiency, but due to metabolism of iron. I think that is make it that explain how this is done. So again, that is how the process is. Lastly, we have how does this anemia? It's anemia which is mild and non-progressive anemia. If you find someone hemoglobin of 2 or 3, you may think about other causes less than anemia of chronic diseases. They are usually normocytic normochronic, but they may also have a microcytic hypochromic. Serum iron and TIBC are reduced. Ferritin is normal or raised. Calcium is normal. And when you go to the bone marrow, they are present. Then the erythroblast iron is decreased. So apart the mechanism of decreased release of iron from the faculty to the plasma, there is also decrease of lifespan of erythroblasts. So instead of 120 days, there will be a decrease of lifespan. So we have said about the cytokines, we have said about epsidine, and so on. So briefly, that is how anemia of chronic disease is there, but also before calling it anemia of chronic disease, you have to make sure that you have excluded other causes of anemia. How do we treat it? We treat first the underlying condition, which may be either infection or inflammation and so on, cancer and anything like that. They have poor response to iron, so no iron therapy needed. You may give erythropoietin, which may improve the anemia in some condition, but also you have to exclude other causes of iron deficiency, of other causes of anemia, including iron, vitamin B12, renal failure, hypersplenism. So to call it like this after excluding other aspects of iron. So I can give an example of HIV/AIDS in the past where the antiretroviral treatment was not available for each one. So they put a requirement that you need to start antiretroviral treatment when the CD4 count is below 200. So most of the people should wait and up to the CD4 of 200, that's when they should start the antiretroviral treatment. So that period, there was a high number of patients with the anemia, but those anemia was just improved by giving antiretroviral treatment. So by giving antiretroviral treatment, the anemia, the hemoglobin have raised, even normalized after just treating the underlying condition. So again, the key element is to focusing on the underlying treatment management. So that's what I can say for now. I think we may need a break. If there's question, we can address the question, but if there's no question, we can take a break. I don't know if it's 1 hour break or what do you advise? Twatangiye dutinze. When are you coming back? We take break now or we continue up to 12:30? What do you think? Hello?
Let's be back at 2.
From now or we continue a little bit?
Continue a little bit.
Okay. Let's go up to 12, then we stop. Any question? If I'm too fast, you can just stop me. Eh? The next point will be on hemolytic anemia. By hemolysis, what do you understand? It's just increase in the rate of red cell production destruction. So here, uh, we say that the normal lifespan is 120 days. Any destruction before the 120 days is called hemolysis. Uh, what are the classification of hemolysis? We have it either be hereditary or acquired. In acquired, we have immune and non-immune. So muri hereditary, we have red blood cell membrane defect. We have hemoglobinopathy. We have red blood cell metabolic defect. So those are the conditions which is hereditary you can get from parents, which may cause hemolysis. Muri acquired, you have immune and non-immune. Among the immune, you have warm antibody type. We have called antibody type, but you have also drug associated. Then we have alloimmune. Alloimmune, when you get some, let's say, blood transfusion from a donor, then you develop uh, hemolytic aspect after having reaction to the donor's red cell. Then for the non-immune, we have red blood cell fragmentation syndrome in case of DIC, in case of malaria, in case of chemical and physical agents, and so on. So clinical manifestation of hemolysis. Hemolysis, you understand that the patient will have a future of anemia, have a headache, chest pain, so on. So fatigue, that is common to anemia. But what is somehow specific hemolysis? They have a jaundice, fluctuating jaundice. They may have splenomegaly. They may have dark urine due to excess of bilirubin. They may have excess of bilirubin causing gallstones. Ulcers around the ankles in case of sickle cell anemia. They may also have a plastic crisis, which is related to the parvovirus. What are the future of hemolysis? We have increase in the laboratory. When there is increased red blood cell breakdown, there will be increase of serum in conjugated bilirubin, urine irinogen, but also fecal stercobilinogen will be increased. Aptoglobin will be absent because it's usually fixed on the free hemoglobin, so there will be decrease or absent aptoglobin. Then on the bone marrow, because there is hemolysis, the bone marrow will try to increase the cell production. By this, that will be reflected by increased reticulocyte counts. That is one. There will be increased bone marrow erythroid hyperplasia, meaning that there will be increased production of red blood cells. Normal ratio between myeloid to erythroid is 1:3:1, but when there is a hyperplasia, erythroid hyperplasia, you may go to 8:1. So that to me mean that there will be increase of erythroid cells. When you go to the peripheral blood field, you may see microspherocytosis. As I show you in the picture, you may see fragmented red cell, elliptocytosis, and so on. You may also have some specific tests which may tell you how long the red blood cells are spending. You may say you the red cells are spending only 20 days, only 50 days, on 60. So it show you in details. So what are the cause of intravascular hemolysis? Most of time it is really mismatched blood transfusion, usually ABO. When you mismatch the blood group of the patient, you may get acute hemolysis. It may be induced by malaria or other infection. It may be drug-induced hemolytic anemia in case of, for example, people getting methyl dopa can also cause that. We have autoimmune hemolytic anemia. We have disease PD deficiency, which cause oxidant stress. We have red blood cell fragmentation syndrome, but also we have paroxysmal nocturnal hemoglobinuria and others. So when there is extravascular hemolysis, there is excessive removal of the blood cell from the reticuloendothelial system to the spleen. So this is the future for intravascular hemolysis. We have said it, but it just increase of LDH, hemoglobinuria, absent hemoglobin, and so on. Reticulocytes, you have remained it, reticulocytosis. In case of microspherocytosis, especially in case of hemolytic anemia, you will see the spherocyte, microspherocyte. You see the small cell, it's like a sphere without a central pala, without, you see how the cells look. Then you have, those are the reticulocytes, which are increased here. Those are
Sorry.
reticulocytes. Yes, please. Yes, I'm
Hello.
listening. Yes.
So may you please comment on the paroxysmal nocturnal hemoglobinuria? What is the rationale behind? Because I don't know why can you have this at night.
It's coming on the next slide. We are still going on. You'll get it. Alikuri slide quick.
Okay.
So I was still explaining on the slide here how the future, which may suggest hemolytic anemia, it just when you see increase of microspherocyte like that. This one you can see it in the peripheral blood smear. Clear? Then here you see what you see. You see red cell fragmented, so we call it fragmented red cell. In which condition can you see this? You can see this in case of disseminated intravascular coagulation. There will be some microthrombus in the bloodstream. Those microthrombus will be causing mechanical damage to the red cell membrane. That will be causing red cell fragmentation. So you see those little fragments there. When you see it, think about either disseminated intravascular coagulation, cyangwa se munafite the mechanical valve causing any mechanical damage to the red cells. Next, you can, what do you see here? You see malaria parasites. Have you been in parasitology? So you can see from the peripheral blood film, ukabona malaria parasite there. Hemosiderimia, deposit of iron in the urine. Then you have the fatty red cell metabolism, starting by glycolysis phosphate dehydrogenase, which is an enzymatic pathway which is interfering the production of glutathione. So glutathione is protective at the red cell membrane, so it protects red cell membrane from the stress and protect it from its destruction. So when there is a deficiency in GCSPD, there will be decrease in the glutathione production, so that will be causing red blood cells susceptible to oxidant stress. Then they can be destroyed easily. So this is mostly found in Black Africans, Caucasian. It is inherited by sex link, so mostly male are the one getting the diseases, and females are carriers. Again, clinical manifestation, it's usually spontaneous hemolytic anemia when there is exposure to the stress. So there are some factors which may induce the hemolysis. So if the patient is exposed to those stressors, so that's when he will develop hemolytic crisis. When he's not exposed to that phenomena, the patient will keep the normal life. So among the oxidant stress, we have some medication, infection, some type of beans. Most of the time, the disease is self-limiting, and also the patient may also have future of spherocytosis and future of anemia. So this is the list of the agents which may cause this oxidative stress to the red cells. Among them, we have said the infection, medication like kefasidas, cotrimoxazole, aspirin. So any of the list here can induce hemolytic crisis to your patient which was in the normal condition. That's how also you can understand the role of knowing the history taking of the patient. Are you have the patient have infection or not? Yes or not? Any medication? Yes or not? So this again help you to make this the diagnosis. So how do you make the diagnosis? Normally, as I said, if there is no issues, exposure to any stress, the patient will be having normal full blood counts without any anemia. But when there is crisis, the patient will have what we call hands bodies, which are oxidative denaturated oxygen, maybe hemoglobin. Maybe I can show you the picture of hands bodies. They have a future of intravascular hemolysis. Then you should also test for the GCSPD assay, which will tell you the level of the level of GCSPD. You can use a fluorescent spot test, and let's say decolorizing test, which again the focus of this is to measuring the level of these enzymes. How do you treat it? Again, remove of offending drugs agents, treat the underlying condition, but also in case of severe anemia, you can transfuse the patient. Otherwise, the patient is need to avoid the precipitating agent, the stressing agent. Nextly, we have acquired hemolytic anemia, which can be either immune or non-immune. In immune one, I want to talk about autoimmune hemolytic anemia, which is caused by the antibody production against own antibodies. So the bodies producing antibodies which will be destroying their own red blood cells. This is characterized by the positive Coombs tests. Coombs test, I think you again repeat it in molecular immunology. We have two types. We have warm antibodies, which is reacting to high temperature. Then we have lower antibodies, cold antibodies, which reacting to the lowest temperature. And we have also antibody induced by medicine. So you can take any tablets, any medicine, then that induce the process of autoimmune process. So how does it work? It's usually red blood cells are coated with antibodies alone or with complements, and they are taken by the reticuloendothelial cell in the macrophages. It can occur at any age and or sex, but it's usually associated with the splenomegaly, hemolytic anemia, and jaundice. So there will be hemolysis. When you want to go to the laboratory, you have seen prominent microspherocytosis. I showed the picture. Polychromasia meaning that there is no centropella, the tendency of high concentration of hemoglobin. There will be neglected red blood cell because the bone marrow is busy producing more red blood cells, so there will be release of the neglected red cell in the bloodstream at earlier stage. Positive direct comes, so meaning that you will see antibody content to the red blood cell. Indirected will be testing the antibody which are still circulating without being coated to the red blood cell. So difference between direct and indirect comes, just the one is positive for the red cell coated to antibodies already, but indirect is the one having just antibodies circulating. Then we have future of extravascular hemolysis. We have the treatment is focused on removing underlying causes, but also targeting the underlying condition, like decreasing the production of antibodies. So by decreasing the production of antibodies, we used to give steroids. When it work, good for the patient. When it does not work, we have to use strong immunosuppressants like azatropine, cyclosporin, or cyclophosphamide. Then we also need to give, in case of severe anemia, we need to give some strong, severe anemia, we should give also blood transfusion. What is the difference between hemolysis? Hemolysis is just, you may see the patient today with hemoglobin of 9. When he's having severe hemolysis, you may find him tomorrow with hemoglobin of 5. So it's like those are the two things to fear. Bleeding and hemolysis may be pronounced if you consider the severity of the condition. Bleeding and hemolysis should be following up like closely to monitor the patient because it may change hours to days. So should be considered. So for now, I think we need to let's stop here a little bit. I have some urgent issues to solve. Then we come back at 2 o'clock, having question and so on. Let's meet at 2 o'clock. Is it okay?
Yeah.
Okay. See you soon.